It's my distinguished pleasure I think most of us know Dr. Azziz, but not everyone. So it's my pleasure to introduce him. You can see some of the information on the title slide here, but Dr. Azziz is an internationally recognized physician scientist and, as you know, an executive who currently serves as CEO of the American Society for Reproductive Medicine. I know he may be looking at doing other things soon, but has led that society here in Birmingham, in addition to being a professor here in the Department of OBGYN. He has previously served in multiple capacities, including being the Chief Officer, Academic Health and Hospital Affairs, and Director of the Hispanic Leadership Institute at SUNY, State, New York, which I didn't know this is the largest university system in the nation. He's also served as president of Georgia Health Sciences University, and then Georgia Regents University, where he also served as the CEO of the health system. Dr. Aziz's research focuses on reproductive endocrinology naturally, as well as androgen excess disorders. He has published, cumulatively, across different article types, well over 500 peer-reviewed articles, book chapters, and reviews. He also, in his research foray, previously served as a deputy director of the Clinical and Translational Sciences Institute, like the CCT as we have here, and also as assistant dean for clinical and translational sciences at UCLA, and as well as director of the Center for Androgen-Related Disorders at Cedars-Sinai Medical Center, Los Angeles. So Dr. Azziz has really been around, accumulated a lot of experience, and I think it's a really a great resource. He has served, and received, among other recognitions, the 2000 President's Achievement Award of the Society for Gynecologic Investigation, and was elected member of the Association of American Physicians. So he's going to talk to us today about PCOS, a common disorder in women, assessing its public health impact and lessons learned. Thank you, Dr. Azziz. Over to you.
Thank you, Dr. Tita. That was very kind of you, and it's it's just great to be back at UAB, and sorry that I'm not there in person today. But I do look forward to that, and Warner, I look forward to those lunches. I mean, that's as you know, anybody in the medical profession is attracted by lunches almost as if we were flies to honey. So that's a good thing. But thank you very much for having me. What I'd like to do today is talk a little bit about some of our research areas and tell you a little bit about what we've learned. It's a conflict of interest you need to be aware of. And so our research area in androgen excess in women, and that's really been the focus of most of our biomedical research, has really been in the areas of adrenal androgen physiology and pathophysiology. We spent about 30 years studying that, most of that time at UAB. We have, study epidemiology, phenotype, and public health implications of PCOS and other androgen excess disorders. We have looked at and studied extensively the clinical and molecular genetics of androgen excess and PCOS. And finally, we've spent a fair amount of time and continue to do so looking at insulin action and adipose tissue dysfunction in PCOS. And I hope to be invited back at some point soon to give you an update on some of these other areas of research that we're doing. But today, we're really going to be talking about the epidemiology, phenotype, public health implications of PCOS, which is really a global interest of ours. Now, why do we bother trying to study global epidemiology and phenotype? Well, for a number of reasons. One, because we want to understand the economic and public health impact of the disorder. As you'll see in a minute, we started this research at UAB, and in fact, UAB was the first to report on the prevalence of PCOS in an unselected population, which became really the leader across the world in doing so, and you'll see that. But it's important to understand, is this a common disorder? Is it costly? Is it not costly? What's the impact? Because that obviously will determine public health policy. The other is the role of underlying environmental and ethnic factors. you don't really understand how to tease out the role of an environment or an ethnicity unless you're able to compare populations, particularly if you've done studies that are comparable and that are obviously use similar techniques. The other reason to do these studies is that we need to understand better the evolutionary and selective processes that led to this disorder. This is an extraordinarily common disorder affecting anywhere between 10 and 20% of women, depending on how you define it. That's a massively high level of prevalence for disorder that is and should be, right? Select itself out, right? It impacts fertility. That is really counterintuitive. At some point in the future, we'll talk a little bit more about the evolutionary paradox of PCOS. But again, seeing and understanding the global epidemiology allows us to study this. And finally, we need to understand the natural history of the disorder. What happens as people age? What happens as they proceed through adolescence and menopause? We don't really have a good idea of these things, and identifying these large populations allows us to do this. But all of this really depends on being able to obtain data that is consistent and harmonizable. It has to be data that actually allows us to compare studies across the globe. We'll start out today's talk with a study on epidemiology, a little bit of epidemiology. Of course, it won't be extensive, but it'll show a little bit of the lessons that we've learned as we've studied this disorder over time. And these lessons, by the way, are really applicable to any other common disorder, any other disorder that is, again, similar to PCOS, a multigenetic type of disorder. We're going to talk about global studies of prevalence, medical bias in the population selection, negative diagnostic bias, and the role of race and ethnicity. Now, as I said to you before, the first study to talk about the prevalence of PCOS in an unselected population was done here at UAB. Eric Knockenhauer was then our fellow, first fellow in the REI fellowship program back in '98. And he published a study which really looked at unselected women at UAB who were undergoing a pre-employment physical. That was an easy model for us to deal with. And it was the first model actually that we used to actually understand what the prevalence of PCOS was. And we used PCOS in a very tightly defined manner. Patients were very well phenotyped. Subjects, again, not patients, were very well phenotyped. And we found that the prevalence at that time was about 4% and about 5% in Black and white women. We had about half and half, if you would, in the population studied, a reflection of the local population. One of the things that we found out early is that there are different ways, different populations of studying it. You have to really try to study large enough populations that are medically unbiased. And that's not an easy thing, right? Because you can't just study populations unless you do so in a systematic way. So the best type of population to study is what is called a population-based study, community-based study. Public health departments were doing a similar study in Ghana, for example. You identify at random households in an area, and then you study the individuals within this household. And this is truly the gold standard, if you would, for unselected medical populations. Very difficult to do, of course, particularly in the United States, but again, doable. Type 2, or what we would call somewhat less optimum, is to use defined populations that are undergoing some sort of assessment for non-medical reasons, health insurances, blood donations, pre-employment physicals, these kind of things. We're working, for example, with colleagues in Eastern Siberia right now to completing a study in which they have assessed PCOS and other reproductive disorders in a large population of women, about 5,000 women, who had to have mandated medical evaluations yearly because of the factories that they work in and so on and so forth. Type 3 is really to study populations that are undergoing an assessment for unrelated medical reasons. For example, you can advertise blood pressure screening or these kind of things. The problem with these populations is that there is some degree of medical bias. The interesting thing for us is that when you look at this, and I'm not going to present the data, but when you look at these type of populations, in PCOS, they generally provide you roughly the same estimate. So even though there may be some bias in these selections, it very clearly shows how strong the diagnostic phenotype, if you would, in the diagnosis of PCOS is in these populations, because the prevalence does not vary very much depending on the type of study. Now, this is a later review. This is Bozdag and my colleague in Turkey, Bulut Yildiz, who did a large most of the prevalence studies at that time. Diagnostic criteria for PCOS, androgen excess, and Rotterdam, and NIH being the tighter one and the one that we tend to use most. And you'll see that obviously as you broaden the definition of PCOS, you'll have greater prevalence of PCOS. But when you use a very tight definition of PCOS, what we call the NIH 1990 or phenotypes A and B, the differences are the prevalence is very similar to this. Very uniform. Now, there are large parts of the world that actually have not been studied. We have studies in North America, as you'll see here, lots of studies throughout Europe, into Asia, in China, and in Australia. But we do not have studies much in Russia, in Africa, and very few studies in Latin America. And so what we've done is we've begun to do and implement studies here. We have the large SPEP, and that's Eastern Siberia PCOS epidemiology and phenotype study in here, which I mentioned. We have two studies in Africa, one in Ghana, one in Nigeria, and one study developing in Colombia to try to address this factor, because these are large chunks of the globe that we do not have any understanding of what PCOS looks like or what its prevalence is. Now, what kind of things can you actually understand from these populational studies? Well, this is just one example. It's just an example, but we often talk about how obesity is a determinant of PCOS and how obviously the more obese individuals are, the more likely they are to have PCOS. But that's actually untrue. In our data, in lots of different types of data, it's untrue. But this is one of those data. If you compare, for example, the BMI of a specific population across the globe, these are various different populations that were studied, versus the percentage of PCOS, you will find that there is absolutely no correlation. No relationship between the prevalence of PCOS in a population and the population's mean BMI. So in general, we don't think that BMI is driving the prevalence of PCOS. It may be driving the morbidity. It clearly is driving a lot of the comorbidities of PCOS, but it is not driving the prevalence per se of PCOS. Again, this is the kind of information that one can extract from large epidemiologic studies that are done across the globe. Now, one of the things that we ran into early on in our epidemiologic studies was that there is a negative diagnostic bias against PCOS. To diagnose a patient with PCOS, there's a minimal diagnosis requires you to do a history and physical, perhaps a transvaginal ultrasound, blood testing for sure, and you need to follow up these blood tests in case they're abnormal, right? That's why you do the blood tests. To diagnose a control, it's fairly easy. You do a history and physical, you might do an FG score. You generally don't do a transvaginal ultrasound. You don't do blood tests because blood tests obviously don't tell you whether somebody is normal or abnormal. Blood tests will tell you what the normative ranges are of that particular population. So this requires you to do a lot more steps to diagnose PCOS or any other kind of common disorder than it would for controls. And so what happens is this results in a negative bias from PCOS and an underestimation of PCOS prevalence in these studies, right? Because a greater number of PCOS subjects simply don't complete their evaluation compared to controls. Controls, you generally can do this fairly quickly. In PCOS, you have to do successive testing. So one approach that addresses negative detection bias that we reported on is to work on what we call assigning a diagnostic weight to those individuals who are not completing an evaluation. So you have this large epidemiologic studies, you've studied 2,000 people. Of the 2,000 people, 200 of them you suspect of having PCOS. And what you do is you take these women that are in the group of possible PCOS and you break them down according to clinical phenotypes. In other words, phenotypes that are that you can define right there when you do the history and physical of the patient without testing, without other issues. And generally we define them as hirsutism and oligoamenorrhea only, or hirsutism only. And these are the three clinically diagnostic categories. We then find out the number of proven PCOS patients in each of these categories, proven not proven, and possible. And then we finally assign a diagnostic weight to the remaining subjects that we think are possible PCOS by simply taking the number of proven PCOS over the total number of subjects. So if, for example, patients with hirsutism and oligomenorrhea, 80% of them turn out to have PCOS in the individuals that completed their evaluation, that 80% you assign it to the other group of possible PCOS, and then have an estimate of what the total PCOS prevalence is in the population. If you actually use these kind of diagnostic weighing criteria, you'll find it does have an impact. These are two studies actually that we did at UAB a number of years ago. So in our first study done between 95 and 96, in which we only considered individuals completing their evaluation, we had about a 4% incidence of PCOS. Alternatively, when we included those individuals who were incompletely evaluated as possible PCOS and assigned them a diagnostic weight, and that study was done between 98 and 99, we found that the prevalence had increased to about 6.5%, about a 30% increase in the prevalence. So again, it does make an importance. It's something that you need to keep in mind as you study complex common disorders, because again, these tend to require more diagnostic processes to establish the disease than not to establish it at all. Now, what about race and PCOS? Well, you know, there's as much discussion about health disparities. I'm going to touch on this a little bit different. This is an early study that we did comparing Mexican American women to Black American women to white women. You will see that there is definitely a decrease in PCOS, but I will caution you that in fact, this study taught us early on that if you did not have comparable methodologies, it really didn't make a lot of sense, right? And so I'll show you some newer data regarding this, but again, the key is that these populations, particularly Mexican Americans versus Black and white, were evaluated using different technologies, and so hence that may reflect the differences in prevalence. We're also looked at phenotyping. In other words, in order to understand what PCOS is, you have to understand what it is, right? I mean, you cannot do epidemiologic studies if you don't actually understand how to define it. And so I'm going to talk a little bit about criteria versus phenotype versus features of PCOS. We'll talk a little bit about defining the features of PCOS, defining what normal is, which often we tend to forget, and referral bias in the phenotype of PCOS. The things that came up early, and we reported this in our initial report in 2006, and then subsequently, is that there are generally three different criteria of PCOS. There's the NIH 1990, which is really came up from a summary of a conference. All of us voted, and it was very exciting because if you weren't there, you couldn't vote, and then you couldn't have your word said. So it was very unscientific, right? It's the issue of consensus science. Rotterdam, 2003, many of us got together in the room, gave lots of lectures about PCOS, never talked about the definition. And then we had 2.5 hours to just yell at each other until we came up with a definition because we had a party that we had to go to in a hurry. And then Androgen X is a PCOS society. They did a much better, I think, because I authored that, but more importantly, you know, we did a scientific kind of rationale, but again, it was an expert criteria. So the point is that none of the actual definitions of PCOS were actually truly based on science, a little bit the Androgen Nexus and PCOS Society. But what we found out over time is that actually these three definitions, all they did was reflected different phenotypes, what we then called phenotype A, B, C, and D. So NIH 1990 only defined phenotypes A and B, what we call classic PCOS. They have androgen excess, either hirsutism or hyperandrogenemia or both. They have ovulatory dysfunction, and they may or may not have polycystic ovaries. Phenotype C is what we normally call ovulatory PCOS. These are patients who have androgen excess and polycystic ovaries, but do not have ovulatory dysfunction. And again, this phenotype C, is called for in Rotterdam, as well as the Androgen Excess and PCOS Society. And finally, there's phenotype D, or what we call non-hyperandrogenic PCOS, which doesn't have any evidence of androgen excess, has ovulatory dysfunction and polycystic ovaries, and it's only called for in the Rotterdam criteria. As you'll see, the data suggests that perhaps A and B are very similar. C is pretty similar to A and B. D is quite different than the rest, and we'll talk a little bit about it. Now, one of the things that actually you can never forget is that PCOS is a diagnosis of exclusion. It's important that you always exclude other mimicking or similar disorders. So if you have a patient's ovulatory dysfunction, you will check a prolactin and a TSH. If a patient has androgen excess, you will check symptomatic hydroxyprogesterone to screen for non-classic adrenal hyperplasia. And we've talked a little bit about that at Grand Rounds, but again, it's important to understand that PCOS is a diagnosis of exclusion. Now, what have we learned in regards to defining the features of PCOS? You know, we talked about phenotypes A, B, and C, and D, and we talked about the fact that the features are androgen excess, either clinical or biochemical, ovulatory dysfunction, and polycystic ovaries, right? And so these are the features defining the different types of phenotypes of PCOS, in this case, 4 phenotypes. And so what we found, for example, studying the total testosterone, and again, this is studies that were began at UAB, you will find that about, if you look at our population, this is a very large population of individuals, using the 1990, the classic PCOS definition, using very high quality sensitive RIAs, you find that about 75% of PCOS patients with NIH 1990 will have hyperandrogenism of some sort. 75% will have an elevated androgen, whether it's total, free, or DHEAS. Alternatively, if you use the same population, but you only look at total testosterone, and again, measuring using a high quality RIA with extraction chromatography, only 33% of patients demonstrate hyperandrogenism. And so this is something that we need to understand, that if we try to do studies, for example, only with total testosterone, which is very common globally, you'll miss about 2/3 of patients who are hyperandrogenemic. And so again, about 50% of PCOS phenotype studies out there assess only total testosterone. And again, their detection rates, because they actually use even less accurate total testosterone measurements, really is well less than 30%. This is key. So when we need to determine androgen excess in PCOS, you need to use high quality androgen assays. This is a study that we did with collaborators in China. We studied 294 Han Chinese patients with PCOS and met the Rotterdam criteria, the broader criteria that we talked about. We compared total testosterone by LC-MS, liquid chromatography mass spec, and also CLIA, or chemiluminescent assay. And what we found is that total testosterone measured by mass spec was found to be a strong predictor of the presence and degree of clinical hyperandrogenism. In other words, it correlated with the bioassay, if you will, the presence and degree of hirsutism. And you can see here in the RNC curve in the blue line the LC-MS by total testosterone does a better job. Again, not perfect, because again, we're only including total testosterone and not free testosterone. But again, it is better than CLIA. And CLIA here in this setting was very poor, basically did not predict really clinical hirsutism. So again, we really need to measure, and what we've learned from our epidemiologic studies is that while not all patients with PCOS require androgen measurements for a diagnosis, when you do need it, you need to use high quality assays. And unfortunately, that's not the case across the globe. Another issue that we found is that you can use clinical and biochemical features to predict metabolic dysfunction of PCOS. About 75 to 90% of patients with PCOS will have metabolic dysfunction relative to their BMI, and depends on how you measure it. We're not going to get into it today. But what we found is that obviously androgens were often be associated with this. But one of the things that we found is that defining normal, the cutoff of normal, what is the normal level for androgens, was not as easy as you would think. This is a study that we did in collaboration with Quest Diagnostics. And what you found is that if you had a prevalence of about 70% of PCOS in your population, for example, patients who see me in the clinic, I always laugh because I say they have the Azziz test, right? Because by the time they come to see me, 89% of them are going to have PCOS the moment they walk through the door, okay? So when you have a clinical setting where 70%, there's a 70% prevalence, your cutoff levels for total testosterone, and this is again using mass spec, is about 35 nanogram per DL for total testosterone, about 3.5 for free testosterone. But alternatively, if you actually use these values that were set up for the prevalence for a clinical setting where the prevalence is high, and you don't adjust them for epidemiologic studies, in this case, assuming a 10% prevalence of PCOS, then you will use a much lower value, because when you actually use the 10% of prevalence, you actually will need to use a much higher cutoff level for total testosterone and free testosterone, in this case 4 and 4. So again, when you're setting the normative values for an epidemiologic study, you need to understand the underlying prevalence of the disorder you're trying to assess. We found somewhat a different finding when you looked at hirsutism, the Fairman-Galloway score. This is, again, familiar to many of you. This is the way we assess hirsutism in women. This is the modified Fairman-Galloway score because we don't use the lower legs and the lower arms. That's why it's modified. There are 9 body areas: upper lip, chin and neck, chest, upper abdomen, lower abdomen, or what people call male scutcheon. There is upper arms, thighs, front and back, upper back, and lower back. And again, you're looking for terminal hair in these areas. If you don't see any, it's 0, and so we don't mark it. If you see a little bit, it's 1. More than a little bit, but not quite that of a male, it's 2. A male that's not very hairy, it's 3. A male is 4. And that's how you define this. And again, it's subjective, although we have published a number of years ago a color atlas available on the web that you can download from Human Reproduction Update. And that allows you to sort of standardize your Fairman-Galloway scores. Now, how do you define normal? I mean, how much hirsutism or how much terminal hair growth in these bodies areas is too much? That's something that we are continuing to do. We actually are working with a number of people to do this, but this is an early study that we did, again, using data from UAB in 350 Black and 283 white unselected women from UAB. And when you do a cluster analysis, in other words, you look for the natural cutoff, what you find is that the natural cutoff for hirsutism is a score of 3. And at that point, it's a score of 3. And anybody above 3 had much higher propensity for having PCOS, much higher number of reports around PCOS and hirsutism. They had a lot more use of electrology. They felt that they were hairy, et cetera. Individuals with scores of 2 or less, analysis back then indicates that a score of 3 indicates a normal terminal hair growth. This is different than what we often hear. Very often, we hear that a cutoff of 8 is what is defined, and that is based on the 95th percentile of normal, which has nothing to do biologically. There is no biological reason why the 95th percentile should be abnormal versus the 90th percentile versus 96 versus the 82 versus the 71. I mean, that's just using percentiles to define normal and biological parameters is a bad idea. So we'll talk more about it, but just so you understand that for FG scores, we tend to use cluster analysis. We currently have organized a multi-center study group, which will be looking at this in a very large unselected populations across the globe, including Australia, Turkey, China, Iran, Korea, and the US. So we'll have a better understanding what the cutoff is. Now, another lesson that we learned during our epidemiologic studies was the impact of referral bias. We were surprised that when we looked at patients in the clinic, and we have seen thousands of patients in the clinic, they look somewhat different than the patients that were picked up in PCOS patients that were picked up when we did our epidemiologic studies. And this is one slide of that. Actually, it's from data that we published. And you can see that when we compare individuals in the clinic, and in the blue is PCOS patients diagnosed in the clinic. In the red is unselected patients, so PCOS patients in unselected populations. And in the green are unselected controls. You can see that that they are not all the same, right? Patients in the clinic were more frequently non-Hispanic whites than patients in the population, more frequently obese, more frequently had higher testosterone levels, and so on and so forth. This again, this first parameter, the greater proportion of non-Hispanic whites among the patients with PCOS seen in the clinic, really speaks to the health disparities that we still face in this nation and to the inequities that we face racially regarding access to health care. The obesity referral bias that we're seeing here really refers to the fact that obesity is the primary #1 driver of patients to see a physician for PCOS. It isn't infertility. It's not even hirsutism, although that's the second most common cause. It's not irregular periods. It's obesity. And so that's why patients who are in the clinic, seen in the clinic, tend to be more obese, which gives us the perception that obesity is much more prevalent in PCOS than it actually is. When we looked at this in a larger population, we did a meta-analysis of various studies that have been published to compare referral populations with unselected populations. What we found is that the phenotypes that I had referred to earlier, phenotypes A, B, C, and D, also differed between patients seen in the clinic and PCOS patients seen in unselected populations, what I call in the wild, right? So there was a lot more patients with phenotype A, the complete classic PCOS phenotype, in patients seen in the clinic rather than in unselected populations, less phenotype B and less phenotype C in the clinic, and about the same with phenotype D. So again, patients seen in the clinic tend to be much more classic PCOS than patients that you tend to see in referral unselected, in unselected populations. This is again, this meta-analysis showing that obesity did not seem to be very different when you compare unselected patients, PCOS and unselected populations to controls, but it seemed to be much higher in referral patients. So what happens is when you look at referral bias, you tend to have a greater emphasis on obesity and insulin resistance, greater emphasis on a hyperandrogenic phenotype. You have some difficulty matching PCOS and controls for age and BMI because PCOS patients tend to be more obese and younger. Controls tend to be larger, tend to be thinner and older. And this all brings up the issues of how generalizable are most case control studies done in PCOS. They are certainly valuable. They may not be as generalizable as we'd like it to be, and that's something that we'll continue to study. Now, shifting gears for a minute, I tend to work in the public health arena. I'm a fellow of the Rockefeller Institute of Government, for example, and I tend to work a bit in higher education policy. And policy in general should be based on data, right? And part of the data that we often use for estimating, for investing, if you would, or governmental investing in a disorder is to understand its public health burden, its economic impact. And so we went ahead and began to study economic burden and other longer costs of the disorder. This is a recent study that is currently in press that we are finishing, but this is a study in which we estimated the health-related economic burden of PCOS patients up to about age 54. We couldn't really find very much data in older patients because those studies aren't there yet. We're hoping to continue to do some of those studies. But if you look at basically the economic impact related to the initial evaluation, to the treatment of menstrual dysfunction, infertility, and hirsutism, the treatment of pregnancy-related complications like gestational diabetes, gestational hypertension, and preeclampsia, and to the long-term morbidities related to type 2 diabetes and stroke, the economic impact that we estimated in 2020 US dollars is about $7.9 billion. This is a conservative estimate. We used only the NIH 1990 prevalence of about 6%, as I showed you in earlier studies. Many later studies show that the prevalence is closer to 10%, even using classic NIH criteria. We did not include the costs of myocardial infarction because we could not find very good data defining the risk. So again, it's a conservative estimate, $7.9 billion cost per year. This is added costs per year related to PCOS. Not an insignificant disorder. It's interesting that you actually can take some of these parameters, as I was saying, some of these clinical predictors and predict the degree of metabolic dysfunction in these patients. And in other words, the risk of morbidities. This is a study we did a number of years ago, correlating, for example, the differences in menstrual dysfunction. These are patients with PCOS who were ovulatory. These are patients who had polymenorrhea. These are patients who were who had regular apparent eumenorrhea, but were actually anovulatory. Patients who had cycles 35 to 45 days in length, 6 weeks to 3 months, and greater than 3 months. And you can see there's an almost linear relationship between the severity of menstrual dysfunction and the, in this case, HOMA-IR level, a measure of insulin resistance in a population. So again, the more severe menstrual dysfunction a patient has, the more likely she is to have metabolic dysfunction. If you look, for example, at androgen levels, we did the same thing looking at androgen levels. What you find is that the best predictor of androgen levels actually is fasting insulin and HOMA, indicating that, again, androgen levels really tend to be good predictors, not so much of hair growth, although we showed some of that earlier, but also that insulin is related to the FG score. So the more hirsute an individual is, the more likely she is to be metabolically dysfunctional. These are all tools that one can use in implementing public health programs to screen for and to try to predict individuals with these disorders. Again, this has been done in other large studies as well, nurses' health studies, et cetera, not focused on PCOS per se, but focused, for example, on menstrual dysfunction. The phenotype of PCOS is also a good predictor of metabolic dysfunction. This is a study of many where you can see that phenotypes A, B, and C, these are the hyperandrogenic phenotypes, tend to be pretty good predictors of metabolic dysfunction, in the case metabolic syndrome, but phenotype D, or the non-hyperandrogenic type, is not a good predictor of metabolic dysfunction. So I think one thing that we need to take from this is that, one, the economic burden of PCOS is significant, related to a number of complications, and that many of these complications, diabetes, stroke, et cetera, can be predicted by simple clinical measures, clinical measures like menstrual history, a degree of hirsutism, things that do not require a lot of assessment. One of the things that I think is important is that these economic burden estimates and these estimates of the prevalence and epidemiology, quality of life, and other factors that impact PCOS really should determine public policy. But our own research has shown that, in fact, there's a break in public policy related to PCOS. So you would assume that PCOS, and because of its high prevalence and economic burden, would be well funded. The research would be well funded, and it actually is the opposite. We did a number of studies that we published a couple, 3 years ago, looking at PCOS and comparing NIH funding to other disorders in women, endometriosis, uterine fibroids, and other larger systemic disorders with similar morbidities, systemic lupus erythematosus, rheumatoid arthritis, and tuberculosis. And you can see that all of them had much greater funding than PCOS. Okay, this PCOS here, PCOS right here. And you can see that, in fact, PCOS funding has been decreasing on a year-to-year basis. The only other one that decreased was rheumatoid arthritis. Everything else went up as well in this regard. So lupus actually went down a little bit. So in general, we find that PCOS, and there's a lot more data here, is underfunded by the NIH at the time. And part of that is that Most of the funding for PCOS comes from the NICHD. The NICHD is primarily interested in reproductive outcomes, not in the metabolic dysfunctions and so on. Those tend to be the purviews of NHLBI, NIDDK, and National Institute of Aging and others. So that's something we're working with government officials to try to remedy. A little bit disheartening is the NICHD itself does not have a PCOS as part of its strategic plan. It's not even mentioned there, which is sort of an odd thing. And again, that's something that we're going to be trying to correct over the years to come. One additional concern really is the fact that not only is research underfunded by the NIH, but really there is, an additional concern that there's a drop in the number of submitted applications for PCOS research from the period that we studied, 2006 to 2015. Between the early 5 years of 2006 to 2010 and the later 5 years of the study, 2011 2015, the number of PCOS applications almost dropped in half. Really compared to 11% decrease in uterine fibroids, no change for lupus, and actually an increase for everything else that we studied. So this is a major concern because, again, it means that younger investigators are being turned away from the field in a field that really requires an enormous amount of research and affects an enormous amount of patients. So what do we know to finish? And I am trying to make sure we stay on time here. What does the future look like? Well, we need to increase the comparability and consistency and harmonization of studies globally, because otherwise we're not going to be able to compare things. We need to improve the definition of the features and morbidities of PCOS by ethnic group and by region to better understand things like health disparities. We need to estimate the economic and public health impact globally and better. Remember, I only mentioned that we did an economic burden impact of disorders that are directly linked, right? We have not looked at things like time of work lost, loss of productivity, mental health issues, and so on and so forth. We need to determine the role of the underlying environmental and ethnic factors in the prevalence in the phenotype of PCOS. We need to better understand the evolutionary and selective processes around this by looking at associated genetic variants across different populations. And we need to assess better the natural history of the disorder by undertaking longitudinal studies of well-phenotyped subjects. Now, what are things that we've done? I'm not going to read these things, but this is just to tell you that we recently published recommendations for epidemiologic and phenotypic research in PCOS. This was a Androgen Nexus and PCOS Society resource document. It's been very well received. Again, it speaks to how can we harmonize studies across the globe in a better manner. We've looked at other ways of trying to do phenotypic studies and screening studies in large populations. This was, for example, an experiment that we did looking at 345 community-based individuals that responded to an advertisement, and we screened them for PCOS. They simply responded to advertising calling for women's health. That was the only information given. And you can see that, in fact, the positive and negative predictive value of this questionnaire, which was simply a 2-question questionnaire. Do you have frequent or irregular cycles, and do you have male-like hair growth on your upper lip and chin and chest, was very high. So again, with just 2 questions, you could screen large populations in this regard. We recently began to look more at health disparities in women, and at this point, we did a couple of meta-analyses, one that's published, one is in yet to be published, looking in this case comparing Black and white women and Hispanic and white women with PCOS. What we found is that Black women with PCOS had a greater tendency toward adverse cardiometabolic risk profile than white women, and as did Hispanic women with PCOS. At this point, we don't really have studies on the outcome of these things, cardiovascular events and mortality. So we can't really speak to this, but these are, again, the type of studies that we're beginning to do using our epidemiologic data. This is, again, a study that we recently did comparing, comparing Black women in California and Alabama. We compared 2,202 women Black women from Alabama with 183 women from California. What we find is that while there was no significant difference in BMI, Black women in Alabama had significantly higher rates of hirsutism, and the same observer, which was myself. And they also had much higher rates of insulin levels and insulin resistance. And these data really indicate that there are geographic differences in PCOS within a single racial group, even in the United States, which requires us to study much more carefully the environment in which these individuals are developing. So again, this is some of the lessons we've learned in the public health arena, looking at the epidemiology, the prevalence, comparing different populations, understanding the inferences of bias and referral bias and so on and so forth. And at this point, I want to recognize a large number of collaborators. I've had a large number of collaborators, thankfully, throughout my career. But I will say that my current collaborators include Uchi Eze, who's out in California, Marla Lujan, who's in Cornell, Ida Chen, who's at Harbor, Mark Gudarzi and Margareta Pizarska at Cedars, Barbara Gower here at UAB, a large number of international individuals in Australia, Russia, Ghana, Netherlands, Nigeria, Colombia, China, and Portugal. So with that, I'd like to stop and thank you very much for your attention. Hopefully we'll have a little bit of answers, a time for question and answers.
Ricardo, that's just fantastic. Thank you so much for that presentation. We have about 10 minutes for questions, so please feel free to drop questions in the chat box or to go ahead and unmute and ask. Any questions?
That was a lot of data. I also appreciate, I speak quickly, and Zoom doesn't allow us to have that personal interaction, which I enjoy. But let me know if you have any questions, particularly around global epidemiology or global studies in PCOS.
Any questions? So I have one. Again, that is just a terrific overview of PCOS epi. For, say, the residents and maybe some students or just other investigators who are on, Ricardo, what are some of the immediate opportunities for collaboration, perhaps here in the US or even in some of the global settings you're working in? And so what are some of the maybe 2 or 3 top questions for small projects that you would see?
So I can say that there are a large number of questions. Oops, sorry.
Go ahead, yeah.
Let me just, large number of questions that we have assessed. And part of that is, again, looking at patients that we have seen in the past and looking at them currently. We also have a very large database of patients here at UAB as well as Cedars. So we have 50,000 samples, aliquots, I should say, not samples, 50,000 aliquots of about 5,000 samples stored at UAB to look at different issues. We have actually completed experiments we never did. I should always tell the residents here that almost every single UCLA fellow over the last decade has completed a project or their thesis with me, and that is because we look at experiments that are accessible, that are easy to understand. Not saying they're easy to do, but I'm just simply saying they're easy to understand. And we have a lot of material, so it's very helpful. For example, we currently have a study right now that we'd like to find collaborators with, to study looking at the predictive value of insulin measured during oral glucose tolerance tests in PCOS. As you know, this is a type of technique that is actually relatively easy in the clinic to determine, again, hyperinsulinemia, because it's hyperinsulinemia that matters, not insulin resistance at month. That's a study that actually we're looking to find a resident or fellow to help us with, to collaborate with. We have studies in other countries that may be of value, but again, those studies tend to be a little more difficult for residents to get involved, just because they involve obviously a lot more logistic issues. Anyway, anybody who's interested in this particular area, please let me know, and we'll work on making sure that they have either a research project for their residency or a thesis if they're a fellow. So that's always easy.
Ricardo, I thought that was great. Could I ask a question about the natural history of PCOS patients after menopause? I wouldn't imagine menopause is curative. So do they continue to have metabolic dysfunction into their later years?
So that's a very good question. There are a couple of 3 studies looking at PCOS women in the menopause. They tend to be small studies because, of course, you have a follow-up issue and so on. What we know is that androgen levels tend to drop as patients go into menopause, but they tend to be relative drops. So PCOS patients tend to be on the higher side of androgens during their lifetime, and they'll continue to be on the higher side of androgens in the menopausal years. It's very interesting that over time, their androgens will drop, but they will drop relative, right, to the issue. So they'll remain somewhat hyperandrogenic. Hirsutism tends to decrease. Ovulatory function tends to improve closer to perimenopause, as you would imagine. So in fact, they tend to have a clinical improvement. They do have a worsening, of course, of their metabolic function. But what's interesting is when you begin to look at the incidence of morbidities relative to other controls in later life, 60, 70 years old, you cannot find as much of a difference in the morbidity. That's why, for example, our study, when we looked at economic burden, we looked only up to the age of 54, because after that, you would actually see that the difference disappeared. And that's because age then becomes such a massively dominant risk factor for myocardial infarction, diabetes, et cetera, that it tends to actually, unless you have very large populations, tends to blur out, if you would, or mask the risk of PCOS. So what I would say to you, in the short term, we know that clinically they're going to get better, at least from a hirsutism, ovulatory dysfunction point of view. Metabolically, they're going to get worse until age catches up to them, and then they're all going to be worse, if you would. I should also point out that at some point I'm going to bring a project to you all looking that will allow us to look at PCOS women in menopause. As many of you know, we saw a large number of patients between 1987 and 2002 with PCOS, of which we still have many of their samples. We have much of their data, and they are hopefully, many of them remain close to UAB in the in surroundings. And so that's a project that we're going to undertake in the next year or so. But at this point, really, there are a few other projects that we're needing to face.
So that's great. And this is the first time we are doing this. And I realize in the conference room, it's muted there. So if there is anyone in the conference room who has a question, this is your opportunity to go on mute and ask the question. We'll just give about a minute here for that to happen. And
I have a reputation for asking people questions. So if there's nobody that's asking me questions, I'm going to start asking questions. So you better hurry before I start asking people questions.
All right. Well, you know, as you were speaking, Dr. Azziz, I looked up and I saw that there is an NIH notice of special interest that's out now for R03, R01 grants through 2023 around PCOS, which I think speaks to addressing some of the issues around funding you raised.
Well, we had heard that was coming up. So if you have it, please send it to me.
Yeah,
so that'll be my administration is administrative duties have sort of cut into my my notices.
All right.
But anyway, listen, I look forward to talking to everybody, and I really look forward to being in that conference room with lunch and all those good things, because it's been years. I don't know how to behave, so I may not be able to behave very well with real people around me.
Well, I'll get back to that. Thank you so much, and thanks everyone. We'll turn it back to.
Thanks everybody. Bye-bye now. Thank you much.
Thank you. Turn it back to the program.